Let's look at healthcare providers who dramatically improve their ability to deliver care to patients by creating an ever more coherent, well-integrated system based on their ability to see problems in the delivery of care and improve upon those situations, and do so because they had a reliable way of escalating problems to a successful resolution. So here's the setup. Allegheny General Hospital, a hospital in the Pittsburgh region. We're talking critical care, intensive care. In those units, some 1,750 patients received a central line in a particular year. Of those 1,750 patients who received a central line, 19 died. Now the end of the story, where we're going with this, is that when this work was done at Allegheny General Hospital, the number of patients in those critical care units went up, the acuity of their conditions increased also, and the number of infections leading to death went to 0. 19 to 0. Now to put this in some context, many central lines are placed every year. In fact, nearly 50% of all intensive care unit patients in the United States get central lines in a given year. Of the patients who receive these lines, many patients, about 200,000, get infections that are very costly to treat. The rate of successfully treating these patients is actually very low, leading to a very high mortality rate. So when we start looking at Allegheny General Hospital and its experience, taking its infections from 19 down to 0, bear in mind the problem they were addressing affects many. So what's going on with Allegheny General Hospital? Well, first, they had to help people who were responsible for either placing central lines or maintaining central lines, understanding what a reasonable normal was so they could recognize the weak signals of abnormality occurring. Now the first of these things that they had to do was help residents, those on rotations through the unit for 6 weeks, 12 weeks at a time, recognize that being in a situation at night where a central line was needed and they couldn't put the safer of two types in place, that was an abnormality. What I mean specifically is that a central line can be put into a patient in two different locations. One way to do this is called a subclavian placement. The catheter is snaked past the collarbone to the center of the body and from there into the circulatory system. This is a little bit tricky because you have to steer clear of the other structures nearby. In particular, there's a risk of collapsing a lung. The quicker and easier approach is what's called the femoral placement. This gives you a straight shot up through the person's groin into the circulatory system. The problem is a femoral placement is more prone to infection because the groin is far dirtier than the collarbone area. When the folks at Allegheny General started reviewing their charts, they realized they were doing an awful lot of femoral placements. When they asked the question why they were doing so many femoral placements, they realized many of the femoral placements were being done on night shift. And why were they being done on night shift? Because on night shift, you had residents who were rotating through the units 6 weeks, 12 weeks. They might not be specialists in intensive medicine. And so when they judged that a patient needed a central line, they said, I got a choice here. In the long term, a subclavian placement might be less risky, but a femoral placement is much less dangerous in the short term. I'm going to do a femoral placement and hope that someone moves the line going forward. Now, think about this. In most organizations, the less skilled resident being left alone on call at night is normal. And the reason they're left alone at night is because they're the junior person. The fact that they don't know how to do a subclavian placement and default to a femoral placement is also normal, but not at Allegheny General. They had to start defining for people that normal is subclavian placement. If you find yourself unable to do that, that's the abnormal to which you have to call attention. It was in calling attention that they realized they had this problem with training, and they said, you know what, we have to give ourselves the time and the resources to solve this problem around training before we leave junior residents on their own at night, forced, mind you, to do a subclavian placement. But they started asking, well, how long would it take to get that solution in place? And they realized, well, we've got certain schedules which are kind of baked in place already, and training is going to take a little bit of time at least to develop and adapt and apply. So in the short term, they said we have to take this abnormality into normal. And the new normal they defined was even if a less skilled, less experienced, less expert resident at night did a femoral placement, that in the morning, the more experienced specialist in intensive medicine, the fellow, would move that femoral line and replace it with a subclavian line. That became the new normal. Now again, Think about what happens in an organization in which those lines don't get moved in the morning. They say, well, after all, patients are difficult, healthcare is difficult, and ordinarily, this happens so often. The fact that we've said we want these femoral lines replaced by subclavian lines, the fact that it didn't happen is normal too, but not at Allegheny General Hospital. They defined for the staff on the morning shift that normal is a femoral line gets moved. So when they realized that they had lines which weren't being moved, they did exactly what we talked about earlier. They recognized it as an abnormality. They had someone to call attention. The chief of nursing, the medical director of the intensive units, so on and so forth. They had a way of reaching those people, and when those people were alerted that there was a problem, they showed up with exactly the right attitude. They didn't show up and say, oh, what was the problem with the night resident that he put a femoral line? They didn't show up and say, oh, what was the problem with the fellow that he or she didn't move the line? They showed up and said, what's wrong with our system that the fellow didn't know to move the line or wasn't able to? And they did some root cause analysis on that and discovered that when a fellow came to examine a patient, the fellow might necessarily know to check for a femoral line depending on what part of the patient they were examining. So they had to, having seen the abnormality, escalated the abnormality, responded to the abnormality in the right way, they had to respond to the abnormality with time and resources that they had available to make better, simpler, more reliable the communication from the residents on night shift to the fellows on day shift. Now if you start asking yourself right now, is this it? Is this what they did to close the gap between 19 patients who died and 0? The answer is no. There was no silver bullet. There was no magic solution. Over the course of this effort, there were dozens of changes that had to be made in the placement of lines and the maintenance of lines and the treatment of patients. But common to all the things that got changed was, first, define for people normal so they could recognize abnormal. When they recognized abnormal, make sure that there was someone whose job was to respond to abnormalities, the person who responds having span of authority, span of responsibility to actually bring the pieces together in tighter harmony. Have a way to reach that person to draw their attention to the problem as it's occurring. Make sure when that person has his or her attention called, they show up and ask what's wrong with the system and not what's wrong with the healthcare provider. And finally, make sure that there's time and resources to solve the problems which are seen and which have been escalated for solution.